And we as PTs and PTAs evaluate sensation. So when we describe the results of a sensation test, we typically use the word intact if it seems like a normal test. We might use the word decreased if the patient, wasn't able to identify all the areas, or, we might use the word exaggerated where they seem to have increased sensitivity. You can always use the words inaccurate, absent, inconsistent. And keep in mind that when you're doing a sensation test, you're testing sensation, but you're also assuming the patient is able to understand what you're testing, that the patient understands your directions, like I want you to identify hot or cold. So there is some comprehension or cognition that needs to be intact as well. And you need to assume that patients want to do what you say. They want to do well, right? They're pleasers. So when you say hot or cold, it's really a 50% guess, right? So not terribly hard to guess one of them correct. So making sure that we're really thoughtful in the way we do the testing. So we're going to talk about this as we go. So when you're talking about pain, you're going to test their pain sensation, their ability to identify pain. We typically use a safety pin, and you identify dull or sharp. So you always want to clean their skin with alcohol. You also want to clean the safety pin, or if you're using another device that can do sharp or dull. And you identify with their eyes closed what sharp feels like and what dull feels like. And then as you're testing it, you're changing the pace. You're not going sharp, dull, sharp, dull. You want to change the pace at which you put that pin on. Because again, they're just guessing, right? 50% guess potentially. And so if you don't put anything on their skin and they're yelling dull or sharp, they're not feeling anything because there's nothing touching their skin, right? So for temperature, you want the vial for hot to be 104 to 113 degrees. You want the vial or the test tube for cold to be 41 to 50 degrees. And there's going to be a difference between those two. And you want to show them. You want it to both be in the same shape vessel. So if you're going to do hot and cold, they both need to be in test tubes. One can't be in a test tube and the other item, it just happens to be a cold metal thing that you found in the gym. Because then they could be feeling the item by shape instead of temperature, right? But if they're both in the same shape vessel, like it's both in the same shape test tube, then they truly have to identify the temperature. If it's discriminative touch or light touch, you can use a cotton ball or maybe a Q-tip. You want to say, do you feel it? And then maybe point to the place where they felt it. When you do vibration, you can use a tuning fork that could be applied to bony prominences, like the DIP joints of the toes and fingers, the malleoli, the patellas, wrists and elbows. And you say, tell me if the fork is vibrating, or tell me when the vibration stops. Stereognosis would be having them close their eyes and identify a common object without sight, like maybe a key or a pencil or a paper clip. But make sure you use a different item, for stereognosis. Let them know it's going to be a common item. It should be something. You don't give them the quarter, tell them this is a quarter, and then test them with a quarter. This should be something they should know, a common item. You want to make sure you're changing, again, kind of changing the speed of the contact. You want maybe put a pause. You do too quick, and then there's a pause, and you see if they say, "Oh, I feel that," but there's nothing to feel. You do two sharps and then a dull. You don't always just do sharp, dull, because if they guess one right and they assume you're just alternating, they can just guess the rest of them, right? Make sure you're testing the whole area that you're going to maybe use your modality on. If you're going to use a giant hot pack, you're going to test the whole area where the giant hot pack will cover. Here, this is a tool to test the 2-point discrimination that you saw earlier. This is that ability to differentiate between 2 points touched on the skin at the same time. And that varies depending on the skin across your body. Again, we know that the fingers are more sensitive than the area of the skin on the back. So the highest acuity is in the fingertips with increased number of mechanoreceptors there and those small receptor fields. Again, Braille dots are really, really close together, and Braille readers can read like 600 letters a minute, about as fast as we do reading aloud. So we use this instrument to measure the shortest distance. So we keep making this area smaller and smaller to see how sensitive they are. Because we know with age, there's a potential change with the sensory system, and also with certain injuries, like spinal cord injuries and strokes. And we have normative data that we can use to compare our patients' results to normed data. We want to know, do you feel, when does it no longer feel like 2 points and it feels like now it starts to feel like 1 point? That's when you know how big those receptor fields are, how sensitive your patient's body part is. Again, if you're testing pressure, you can indent the skin like with your thumb or squeeze an area like the Achilles tendon. Do you feel this? And then there's a time maybe don't squeeze it and you say, do you feel this? Kinesthesia is we usually test with passive range of motion. We have the patient relax. We hold, we always want to start with the unaffected limb. You put it in a certain place, you hold it in a static position, and then you start slowly moving it either into flexion or extension, and you say, am I bending your knee or am I straightening it? So you have them identify that. For proprioception, we move the joint into a certain position and then we stop. We often do this with the big toe. And you want to, again, do both extremities, the unaffected extremity, and then the impaired extremity. Sometimes they're both impaired, and you're trying to see, which, if either, have good sensation. Sometimes we use the big toe. Sometimes if people have we suspect they have decent proprioception, we might put one limb or one extremity into a certain position, and then we ask them to put the other limb in that same position. But keep in mind, if you do it this way, you may not be testing proprioception. If you've got a really deconditioned patient who has difficulty moving their limbs, you can't do it that way, because they may have difficulty putting that leg in the new position, not because they have poor proprioception, but because they're weak, or they have pain, or they have arthritis. So you got to make sure you're actually testing proprioception and not something else. Graphesthesia would be recognition of a letter or number traced with a key in your hand. So you'd put them palm up, you'd have them close their eyes, you draw a letter A on their hand to see if they can identify it. Barognosis is, kind of their ability to understand different weights. So you can have them hold different weights in each hand and say, can you tell the difference? Which hand is heavier? Which weight is heavier? There are a lot of diseases leading to sensory deficits. So if we have a peripheral nerve lesion, a neuropathy would be a dysfunction in one or more of these nerves. If there's a complete section or cut of a nerve, like due to like a knife, or again, our knife-wielding lunatic, can result in loss of sensation in the distribution of that nerve, or we could have demyelination of a nerve caused by trauma that could affect maybe a large myelinated fiber, resulting in loss of proprioception and vibration information. A lot of different types of nerve lesions. There are spinal cord or spinal region lesions. You can have a complete transection of the spinal cord, which would prevent all sensation below the lesion from ascending to higher levels. You could have a hemisection of the spinal cord, which is just like half of the spinal cord that's been injured, and that interrupts pain and temperature from the opposite side of the body. It would also cause the patient to lose conscious proprioception, touch, and vibration on the same side of the injury, again, depending on because those tracks cross at different places. There could be a posterior column lesion, which would cause conscious proprioception, touch, and vibration are lost below the level of the lesion. We also have infections. Shingles, varicella zoster, is an infection of the dorsal root ganglion by the varicella virus, which also causes chickenpox. So we often see this with folks after they've had the chickenpox. Oftentimes we see this with older folks or people who are immunocompromised. The virus is transported down that peripheral sensory axon and irritates and inflames the entire distribution of that nerve, causing a ton of pain. The virus is released into the skin, causing these eruptions, which itch and burn. We treat this with antiviral drugs. It tends to follow one dermatome.